everyone to the 11th Annual Northeast Ohio Community Resilience Center State Environmental Determinants in the African American community with a focus on environmental protections. For our next session, we want to welcome to the stage Dr. Allison Cabin-Holt. Dr. Allison Cabin-Holt, who's the Program Director and Researcher at the Maya Angelou Research Center for Healthy Communities, Wake Forest University School of Medicine, where she's an expert in researching racial disparities in Alzheimer's dementia. She has spent much of her career focusing on ensuring that the participants in research reflect the persons who are afflicted by the diseases, particularly Alzheimer's disease. Currently, Dr. Cabin-Holt is working to create a program of research around community outreach and engagement of all people to promote brain health for everyone, everywhere. Recently, she has helped develop and implement a program for increasing knowledge and awareness of Alzheimer's disease that has reached over 200 family caregivers of persons with dementia in the state of North Carolina. And the title of Dr. Cabin-Holt's presentation today will be Disparities in Alzheimer's Disease and Dementia Caregiving. And we want to welcome her to our conference and want to invite your participation, your attention, and your questions, which you can place in the chat once her presentation has been completed. Dr. Cabin-Holt, welcome, and the floor is yours.
Thank you so much, Dr. Williams. I appreciate the kind invitation to present today. And I just wanted to give the audience just a heads up. I'm going to be focusing my talk today on Alzheimer's disease and related dementias, and talking about the risk for Alzheimer's primarily, as well as other forms of dementia. I will give a follow-up presentation about caregiving. When I started looking at everything together, I really feel like caregiving deserves its own presentation. I am Allison Cabin-Holt, and I am a program director at the Wake Forest University School of Medicine in Winston-Salem, North Carolina. I've been working in the field of Alzheimer's and aging for over 25 years. And I'm so excited to talk to you today about Alzheimer's and the related dementias, because there is such a great need for information sharing about this topic. So disclosures, I do have funding from the National Institutes of Health, and that is the only disclosure I have. And today my outline will be that I'm going to give you some dementia basics, talk about heightened risk for dementia, how you might be able to reduce those risks and available treatments, as well as pointing out opportunities for joining research and benefits of research. So to start with, I kind of always throw out the idea of why should we care about Alzheimer's? So first, it is very common. You may know someone who has it. You may know people who are trying to manage a loved one with Alzheimer's. Alzheimer's, we also say, is a family disease. And why do we say that? If one person in the family develops Alzheimer's, the entire family has to gather around that person and provide care. So it doesn't just affect one person, it affects an entire family. And then there are the costs of Alzheimer's. So there are costs to caregiver health. Caregivers, oftentimes of a person who has Alzheimer's disease, will focus in on that person and maybe neglect themselves a little bit. Is the caregiver going and getting all of their medical screenings, or are they so engrossed and so duty bound with their loved one that they neglect their own health? And Alzheimer's disease is a 24/7 type of condition. And so it can be easy for caregivers to lose their own health as they care for this other person. There's also an emotional cost to Alzheimer's disease. To watch someone who maybe in the past had been, so vibrant and so together, not be that person any longer is emotionally difficult for others to watch, and certainly emotionally difficult for the person experiencing the memory loss to go through. And there are the financial costs as well. It does cost more to care for a loved one with Alzheimer's disease, because of the fact that it does require that 24-hour a day type of care. A loved one who is managing a family member with Alzheimer's may have to come out of the workforce. So that right there would take a huge hit on someone's income. But we are also living longer. Another reason we should care about Alzheimer's disease is that we are living longer and are aging into advanced age. This Time magazine cover from February of 2015 says this baby could live to be 142 years old, and that was a decade ago. Just that we know that medical advances are allowing us to live longer. So we also want to live better as we get older. We want continued quality of life. And the greatest risk factor for developing Alzheimer's is age. And so as we have the opportunity to live to be older, we one day may face Alzheimer's disease ourselves. And I forgot to say that AD is my abbreviation for Alzheimer's disease. So we should care about Alzheimer's because it may be us one day. We should care about how individuals who are living with dementia, how they are cared for, how they are being treated, and opportunities that are given to them for the best quality of life possible. So let me give you a few statistics about Alzheimer's disease. So Alzheimer's disease is the 7th leading cause of death among Americans. And in the state of North Carolina, where I live, is actually the 6th leading cause of death. And these are some statistics from a few years ago. At that time, about 6.5 million Americans age 65 and older were living with Alzheimer's. That's a tremendous number of people. And that was a few years ago. I believe that those numbers have increased. And we believe that 1 in 3 people who are senior citizens die with Alzheimer's disease or some other form of dementia. So it is an incredibly prevalent, and we really need to understand it better, understand how to reduce our risk for it, as well as how to manage the individuals who have it as best we can so that they can have the best quality of life. So to give a little bit of background and some terminology, so I want to define what dementia is. So dementia is what we call an umbrella term, and it means loss of memory and other thinking abilities that is severe enough to interfere with everyday life. That is the term dementia. Alzheimer's disease is one form of dementia. It is one cause for memory loss, but it is not the only one. Alzheimer's disease is the most prevalent cause of memory loss in older adults, making up between 75 to almost 80% of dementia cases. However, it is not the only one. The next most prevalent is vascular dementia. Vascular dementia is a form of memory loss that is caused due to issues with our veins and blood flow. Anytime you have blood flow that is not good, that is not making it to the brain, then the brain gets deprived of nutrients and oxygen that it needs to work. And so vascular dementia, you may start hearing a little bit more about it. But vascular dementia is a form of dementia that is caused by issues with vascular disease. Lewy body dementia is a form of dementia that is related to the motor movement and contact and the cortex of the motor cortex, and is very related to Parkinson's disease. Frontotemporal dementia is a form of memory loss that happens when people are slightly younger, more like in their 50s, their 40s and 50s. And it affects the frontal and temporal lobes of the brain. And a lot of the symptoms of frontotemporal dementia have to do with judgment, So some of the judgment and being rational and emotion may be some of the early signs of that form of dementia. There's a form of dementia related to Huntington's disease. And something that you may hear more frequently is mixed dementia. And that means that a person is experiencing dementia from more than one cause. So a person could have Alzheimer's disease, but let's say they also have issues with their vascular system. So they could have Alzheimer's and vascular. That would be considered mixed dementia. So just going back again, dementia is just an umbrella term for memory loss and thinking abilities that are severe enough to interfere with everyday life. But there are lots of forms of dementia, and Alzheimer's is one. And so when we say Alzheimer's disease and related dementias, some of the related dementias are the vascular dementia, Lewy body, frontotemporal, etc. So we're going to talk a little bit about what happens in the brain of a person who develops Alzheimer's disease, and I'll be showing you some diagrams of that in just a second. But there are some protein buildups in the brain that cause things that are called plaques and tangles, and I'll show you a picture of what that looks like. And those are considered the hallmarks of Alzheimer's disease. When a person passes away and their brain is examined, when we see plaques and tangles, that verifies that the person has Alzheimer's disease. Plaques are clumps of a protein called beta amyloid, and tangles are caused by a protein called tau that twists into fibers within the brain cell. And there are drugs in development to target these proteins. So these are some diagrams of what plaques and tangles look like, as well as normal brain cells. So we call brain cells neurons, and we do believe that once brain cells are destroyed, that they do not come back. We believe that we can make our brain cells grow, but that we may be limited in being able to recover brain cells after they die. And so it is important to make sure those brain cells stay active and do not die. So in the first diagram, we have kind of what happens in a normal brain. So you can see that there are two neurons. Here's one, and here's some others. And they are very, very close together in your brain, but they actually do not touch. There's an electrical impulse that goes in between the neurons, and that causes a message to get from one neuron to the next. And that's how we do everything, is that our brain sends messages through our neurons for everything from breathing to walking to talking. And if there's anything that gets in between those connections, or that we don't have as many cells, that is going to affect our ability to think properly. So in the middle, you see what would be considered normal neurons. So you see that they're very close together, they're not touching, and they're full and healthy. The last diagram is what would be considered Alzheimer's disease. And as I told you before, there are these tangles of a protein called tau. They are within the brain cell, and they effectively kill the cell, kill the brain cell, and reduce its ability to work. And then we have these proteins in between, these clumps of proteins called plaques, and they are a buildup of a protein that is called beta amyloid. And as you can guess, if they're being between the cells, they are affecting the ability of the cells to communicate with one another. So you have something within the cell reducing its ability to be effective, and then you have these proteins in between the cells. Between the two, really what you have is that the brain cells are going to become ineffective and die and not communicate with each other. And I'll show you what this looks like in sort of in a real person. So on the left is what a healthy brain looks like. And then on the right, you see an advanced Alzheimer's brain. So what do you notice? You can see that on the left, that brain is full. There's no discoloration, etc. On the right, a person with advanced Alzheimer's, you can see that their brain has sort of shrunken. Why did it shrink? Because there are fewer living brain cells in that brain. There are big spaces. Those spaces are actually because the brain cells have died. And there are structures in the brain for memory, like this area down here, which is the hippocampus, and then the amygdala down here. And you can see that those are effectively gone. Those are structures in the brain that are where memories are consolidated. That's where your memories go into storage. And so those areas are completely gone. So effectively, the plaques and tangles basically kill the brain cells, and then the brain itself shrinks. And if you go back to just thinking about that diagram that we looked at a little while ago, if you don't have as many brain cells, that information that needs to be communicated from one cell to the other, it just can't happen. And so when you see a person who has Alzheimer's, and you imagine that they have a brain that is not functioning well, this is what their brain looks like. You can imagine that they're going to struggle in so many areas. I wanted to tell you just a little bit about the progression of Alzheimer's disease. And what I want to start by saying is that these are estimates. There are people who live with Alzheimer's for much longer in some cases. So these are only estimates, and it is not discrete. People may stay in a stage for much longer than another stage. So we begin by thinking that there is a stage called pre-dementia. So that means that there are those changes, maybe the plaques and tangles are starting to build up in the brain, but they have not gotten to a point where they are severe enough to interfere with everyday life. And we think that that could go on from 7 to 10 years before that person is diagnosed. Then there is a mild stage, which we think lasts a couple of years, a moderate stage for a couple of years, and then a severe stage for a couple of years. In total, on this diagram, it makes it seem like most people have dementia for about 7 years, but there are people who have it for much longer. In the mild stage, you will see memory loss, confusion with familiar places. It can take a person longer just to accomplish tasks that in the past they would have had no trouble with. Some early things might be trouble paying bills, and there's a bill that's not paid, and this could be someone who was always very much on top of making sure their bills got paid or the taxes got paid. Poor judgment. This is definitely a stage where we want to be careful with our loved ones and make sure that they are not falling victim to any sort of scams, telephone scams, people calling them and saying they know them, give me some money. And then loss of initiative. They may just not want to go out and be as active as they had in the past because they are experiencing some confusion. In this stage, people might be able to you might not know immediately that a person is having trouble with their memory. A person might be able to have, a nice conversation at this stage, and you might not know. Now, when we get to the moderate stage of Alzheimer's dementia, you know that this person is having trouble when you encounter them. Increased memory loss, a shorter attention span. They may have inappropriate outbursts of anger, certainly trouble recognizing familiar people like their friends. This is a stage where they may also have more trouble with language, organizing their thoughts, and they might say the same things over and over again. And then some restlessness, agitation, tearfulness. And you can imagine that if you were having trouble with your memory, and let's say you put down you put your keys down somewhere, and then you can't find them. That might cause you to start to think, hey, did somebody move my keys, or did somebody move my stuff? And that can be some of the agitation. You don't remember people as well, so maybe it's like, hey, what is this person doing here? Who is this person? So in the moderate stage, we definitely know that the person is having trouble, and they're not able to sort of hide or mask that they're having trouble. Now, in the severe stages of Alzheimer's, this is where you're going to get weight loss. There tends to be increased seizure activity, skin infections, maybe from a person not moving around as much as they had before, difficulty swallowing, groaning, moaning, grunting, so making sounds, but the person who is caring for them may not be sure, is that an issue, is that pain, or are they just making a sound? And so it can be very distressing for the caregiver to hear these noises and not be able to interpret them, and the person maybe can't tell the loved one what they're experiencing. Increased sleeping, lack of bladder and bowel control. And lack of bladder and bowel control is typically the the thing that happens that causes people to end up in nursing home placement. That is usually one of the big things that occurs, that families often have trouble keeping being able to keep track of that. And so people sometimes, once they lose their bladder and bowel, is when they are transferred to nursing home care. They may have extended stays in bed and certainly have trouble with swallowing and breathing. And so that can lead to aspiration pneumonia. So again, much more difficulty in the severe stage. So I wanted to share the 10 warning signs of Alzheimer's. The Alzheimer's Association has created these 10 warning signs that should a person experience some of these, it does not mean you have Alzheimer's, but it does mean that you probably should get some sort of evaluation for dementia or memory issues. So again, just because a person has some of these does not mean you have Alzheimer's, but definitely would suggest you should get evaluated. So again, memory loss that disrupts daily life, challenges in planning or problem solving. You might have somebody who in the past would have been able to plan a trip very easily, and they're struggling with it, difficulty completing tasks. You may find a person who might have started cooking something in the kitchen and then maybe walked away, got distracted, and then things might burn. And so that is oftentimes a warning sign. Confusion with time or place, trouble understanding visual images and spatial relationships. So, for example, if there was something dark on the floor, the person's brain is not able to process that information. So they may pick up their foot thinking that there's a hole there, and really it's not something that they would fall into. And it's, again, the issues with understanding visual images have to do with the fact that the brain is not functioning properly. The eyes may be functioning just fine, but the brain can't process what the eyes are showing them. New problems with words or speaking or writing, misplacing things, and losing the ability to retrace the steps. So we all do this. We forget, where we left our glasses, and then you got to think about, well, where was the last time I had them? Oh, okay, let me go back to that room. A person who may be having signs of Alzheimer's may recognize they've lost their glasses, but then can't remember kind of like the last time they had them. Decreased or poor judgment, as we talked about, withdrawal from work or social activities. If a person may have been in a job for many years and then suddenly finds that they can't keep up the way that they used to. And then changes in mood and personality are actually some of the early warning signs of Alzheimer's. And maybe what people notice first is that the person might be moody or or picking a fight or something, or it seems like they're picking a fight, but really they're dealing with the struggle of not being able to remember. And we say jokingly that if you can list a number of things you've forgotten, you probably don't have Alzheimer's. So, oh, on Monday I forgot this, and Tuesday I forgot that, and then Wednesday. A person with Alzheimer's does not know that they have forgotten things. They don't know that they're not getting it right. And so a person with Alzheimer's is not going to recognize some of these signs. I wanted to just talk about disparity before we get into some of the risk factors for Alzheimer's and other dementias. So a disparity is a lack of similarity or equality between things, especially in a way that is not fair. And the quality or state of being equivalent is what a disparity, what is the converse of a disparity. And it comes from the Latin paritas, or par, like equal. People might know in golf, sometimes they'll say something that's under par. So that means that it's not equal. The person is over par, so above what is normal or equal, and also we know the term subpar, something that's not good, something that's not equal, and also other words like partner. So when we say disparity, we're saying something that is not equal. And when we talk about health disparities, we're talking about differences between groups of people or causes that cause things to not be similar, not be equal. And the disparities may lead to worse health. There may be disparities in causes of poor health, outcomes from health, access to health care may be the ways that disparities show up. So, for example, access to health insurance is one of the most important predictors of healthcare access. And so, our ability to pay for healthcare, our insurance status can affect our health, and that has been shown to not be equivalent across all groups. Disparities are found even when level of illness is taken into account. We would often think, hey, if I have a certain level, or let's say that I have stage 2 of a certain kind of cancer, then a standard treatment should be administered to me. But we have found that disparities can be found even when 2 people walk in with exactly the same level or the same kind of illness, but may be given different treatments. Disparities are found across a range of medical settings. So we often think, oh, the big fancy university medical center, might be better than like the community, maybe a community setting medical center. But we have found that there are disparities are found across a range of medical settings. And disparities in care are associated with higher mortality among people of minoritized groups. There are social factors that influence health. And I wanted to talk about this touch on this just for a minute before we get into risk factors for Alzheimer's and other dementias. And these factors that you may have talked about earlier have to do with conditions where people live, learn, work, and play, and how those influence their health outcomes. So the key domains include economic stability, education access and quality of education, healthcare access and quality of healthcare, neighborhood and the built environment, and social and community context. And if you think just about, say, a condition like Alzheimer's disease, how might economic stability affect a person? So economics are often tied to where we live. Economics are often tied to our education, and people who may have gone further with their education may be able to live, have a higher income, and maybe live in a place that gives them access to other things. healthcare access and quality. Oftentimes, where we access our healthcare is related to where we work, and so if you have access through your job, um, um, sometimes if you have a job that might be more where you can get away and go to a medical appointment and say, hey, I'm going to be gone for a couple of hours, and you are on salary and it doesn't affect your income. But if you're an hourly worker, being able to get away to go to a medical appointment, if it's going to cost your salary, maybe you don't go even if you have access to it. Maybe making decisions about economically, maybe making decisions about whether you can pursue a particular or take a particular medication if it's too expensive, things of that nature. Neighborhood and the built environment. If your neighborhood is not safe or is not walkable, that may reduce your ability to go and even just take simple walks for exercise. And then we also have social and community context as well. It is important for us to stay connected to our community and stay connected to other people. And we'll be talking about that more. But we do think that, especially as people get older, really at any age, but especially as people get older, to have more people in your life who are keeping their eyes on you, and if there are changes, can help you find resources is important. So here are 14 risk factors for dementia. Now, keep in mind what we've just talked about, which were those social and environmental factors that have to do with health outcomes. And think about, as we go through this list, how many of those are related to something on that list of different factors of the social factors that influence health. Physical inactivity is a risk factor for dementia. Again, if you don't have an environment that encourages physical activity, and your neighborhood and built environment might not be walkable, for example, that might reduce your physical activity and could increase your risk for dementia. Smoking goes without saying, anything that's going to reduce your blood flow or reduce your ability to breathe. Excessive alcohol consumption, there are certainly risks there because, again, the brain having to deal with these alcohol and these chemicals. Air pollution is related, head injury, infrequent social contact, which we just talked about, less education, which is again on that social list. Obesity increases your risk for dementia. Hypertension, diabetes, again, conditions that you need medical care for to reduce your risk. Depression, again, you'll need to get health care, have health care access to effectively perhaps effectively dealing with your depression. Hearing impairment is a new one that has become quite prevalent and quite important in reducing our dementia risk. And then cholesterol and vision loss. So also looking at risk. So those were 14 risk factors. Here are a couple of others for 2 out of 3 individuals with Alzheimer's disease are women. Why is Alzheimer's more prevalent in women? Again, going back to those social, physical, and economic conditions that we've talked about earlier, women live longer, and we've already said that age is your greatest risk factor for Alzheimer's disease, dementia. Lower educational attainment as a group, lower financial status. Women may be more likely to have lower wage jobs and reduced access to medical care. Believe it or not, worse sleep. If you are not getting regular, good quality sleep, we our brain needs time to actually consolidate memory. Our brains need time to rest. And so if we are not getting sleep, it reduces the amount of time your brain has to actually consolidate those memories. Higher stress levels. Apparently, women report higher stress levels than their male counterparts. And just giving caregiving as an example, women make up over 60% of individuals who provide caregiving. And so, as an example, maybe a higher stress activity that women do more of. Let's see, higher prevalence of depression in women, and we already saw that that is a risk factor for dementia. And believe it or not, ironically or paradoxically, we women have stronger immune systems that actually permit greater plaque accumulation. The stronger immune system, we think, has something to do with being able to have give birth, and that makes the immune system a bit stronger, but it also allows more of those plaques to accumulate before some of the symptoms show up. So believe it or not, that is one of the reasons why we think women have Alzheimer's disease more often. And then some racial differences in Alzheimer's disease. Among Americans 65 and older, people of color are most affected by Alzheimer's. Older African Americans are twice as likely to develop Alzheimer's disease compared to older white Americans, and Hispanic groups are 1.5 times more likely to develop Alzheimer's disease compared to white Americans. And oftentimes, minoritized populations may be underdiagnosed, may be diagnosed later in the disease process. And when that happens, again, that reduces the potentials for treatment, potential for participation in research. And why do we think that Alzheimer's may be more prevalent in people of color? So very similar to some of the reasons why we think it is more prevalent in women. Again, social, economic, and physical factors might contribute to Alzheimer's risk as a group, not as compared to non-Hispanic white individuals. African Americans and other people of color have lower income status, and income and education actually have a corresponding relationship. So the more education you have, more likely the more income you're able to obtain, which again leads that cascade of where you work, having access to medical care, and being able to get information about health as well. So health insurance quality, reduced access to medical care may lead to an accumulation, especially of vascular risk factors in people of color in their midlife and late life, including diabetes, hypertension, obesity, which were all on that risk factor list. Reduced opportunities to take part or to get access to healthy foods, again, income related, and pollution. Perhaps living in an area where there may be more pollution, less walkable, potentially. And then differences between groups are reduced when economics are taken into account. So we have all of these risk factors, but if you made the incomes all equivalent across groups, many of these issues that we're talking about in terms of insurance and medical care fall out. So we know that this is not necessarily that we have an influence on how our genetics and our backgrounds are affected by these by some of these factors. So, for example, if we are prone to being overweight, being able to access places where we can exercise, for example, or get healthy food and diet will allow us to reduce that the genetic contribution. So we have some influence on how our genetics play out, and so making sure that we know what our risks are, so we have that opportunity, and then to take advantage of the information we have, because we can't change our genetics. health disparities that you may already be aware of. African Americans are at higher risk to die of stroke, heart disease, significantly more likely to be diabetic, and a greater propensity for obesity. And all of these are related to increased risk of Alzheimer's disease. So what can be done to address some of these gaps and risks to improve our health? I put out there, let's also reduce disparities by participating in research on Alzheimer's. The Lancet Commission in 2024 looked at dementia prevention and intervention and care. And what they found, or what they suggested, was that in early life, getting more education reduces our risk. In midlife, hearing loss, cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, and obesity and excessive alcohol use. If you take any of those things out or reduce them, it reduces your risk of developing Alzheimer's as you get older. And in late life, social isolation, air pollution, and vision loss also can help reduce your risk. And taken together at every stage of life, we believe that 45% of Alzheimer's disease is preventable if taken all of these different factors into account. And again, I always suggest, because I'm a researcher, joining appropriate health research. I wanted to let you know, because you may not know, that there are a couple of medications that actually modify Alzheimer's. That means these two medications, Leqembi and Kisunla, that came out recently, 2023 and 2024, have been approved, and they remove those beta amyloid plaques that we saw in the brain on those diagrams, the ones that get in between the brain cells. But what I wanted to point out, and this is the Leqembi test results, you can see that we have Leqembi and we had the placebo. We had, over 800 people in both of those groups. Age was similar. Male, female is similar. Male, female is similar. But when you come down to look at the racial groups, we're seeing that that over almost 8. Sorry, it looks like we went out for a second. Let's see, I need to share screen again. Share screen. Give me 1 second. I'm getting our slide back up. Okay. All right. And let's see. Okay. Thank you. Sorry about that. I just wanted to point out that for the Leqembi, the number of people of color who were part of that research was very low. So we had almost 80% were our white counterparts, but Black individuals made up only 2% of each of those groups. And that's just not appropriate when you consider that, when these medications go live, that we do, that we are going to want to try these medications. But I have to say that, we should go into it with some caution, since Black people did not make up much of a percentage of this, of these test results. And so we really need to be thinking about that. And we know that there are significant reasons why people of color do not participate. But also we need to find something that is appropriate for us, that we feel comfortable with, and help us to reduce our risk for Alzheimer's disease, if not for us, for our future generations. We want to, when people are eligible for going into research, I encourage people to try to join as early in their disease course as possible. Once a person has had significant damage to those neurons, to those brain cells, they're not a great candidate for medication trials. And we do need generalization. We do need representativeness in the in these research studies, so that we know what are some of the side effects for different groups. We want the treatments and cures to work for everyone, and even a treatment that could halt dementia for even a few years could be a great benefit. If a person could stay out of a nursing home situation, that would be financially beneficial for the family and for the person, as well as it would be probably great quality of life for the person to be able to stay home a little bit longer. And also viewing, I put out there to view research as an opportunity for specialty care. Sometimes you can, as part of your research, maybe you get scans that you might not have gotten otherwise, or maybe you get access to a neurologist or some other specialist that, in order to get access to them through your medical, would take you a long time. So just also an opportunity to have more specialists involved in your care. I just wanted to mention a couple of studies. We have the Dawn research study. I'm part of the Dawn research team, and we're looking at Alzheimer's disease among people of African ancestry. And we're definitely looking for families with people who are age 60 and older. They can have Alzheimer's disease or be healthy volunteer. We do compensate, and we generally come out to where people are. If you are interested at all in participating, there is a QR code. Feel free to take a picture of it and find out more about what we're doing in these opportunities. And then let's see. And then importance of brain tissue donation. I see somebody, I just glanced over into the chat, and they're talking about Cleveland Clinic's program. I did want to mention the importance of brain tissue donation very quickly. It helps us as scientists to understand and prevent diseases like Alzheimer's. Alzheimer's is not the only disease that we need brain tissue donation for. And again, just like many other aspects of research, only about 2% or so of brains that have been donated come from people of African ancestry. And we need to understand both how people live successfully and age successfully, as well as those who develop Alzheimer's and other conditions. And one brain can provide information for hundreds of research studies that impact millions of people. And just want to point out, there's the Alzheimer's Association, there's Us Against Alzheimer's. AARP has lots of resources, and the ADIR study, the ADIR Resource Center, you get lots and lots of like handouts and pamphlets from the ADIR website as well. And this is our Dawn research team at Wake Forest. This is my group, and we are so happy to have had the opportunity to talk with you about Alzheimer's disease today. And if you have any questions or comments, I'm available for that. And this is my contact information. Feel free to, certainly feel free to reach out to me. Thank you.
Thank you so much, Dr. Cabin-Holt. Thank you for your research and the work of your research team and colleagues at the Maya Angelou Research Center, Wake Forest Medical School. I have a couple questions. If you could talk about the the causal factors, as you begin to speak about for African-American women with respect to Alzheimer's dementia, and if there's any pioneering cutting-edge research that's being done, and could you also speak to what is it like to try to recruit African Americans into research groups or trials as it relates to Alzheimer's work, and maybe the misgivings or the hesitancy, and what more can be done to both support that research and the work of caregivers?
So thank you so much for that question. So our research, the Dawn study, has done very pioneering work. We found novel genetic markers for Alzheimer's disease that were not that had not been brought forth before, and the only way that we do that is by reaching people. We invest a lot of time and effort to really try to be in community. You just can't expect that people who are not comfortable with research, not comfortable, talking about disease, to come to the university. Yeah, come on, deal with the parking, come and hang out with us. It's just not going to work. We spend a lot of time going into communities, you name it. I think every year we go to at least 60 or 70 different events, our team. And everything from powwows in the east of North Carolina all the way to going to Houston, Texas, where we're going to be talking with a church there. We have to be where the people are, and to give people an opportunity just to ask questions. People need to have their questions answered. They're not going to get over Tuskegee or Henrietta Lacks until we talk about what are the protections that are in place to protect people from that kind of treatment. I think the other thing that we think is important, and maybe it's because I'm a researcher, is also to have some people who are part of the groups that we want to engage to be at the high levels of the research, not just helping you get the research participants, but also are setting the standards for the research, are answering the questions, are asking the questions that are relevant. And so it certainly is a challenge, but you have to listen to people. And if you think you know everything, then you're not going to make any progress. So when people tell you, "Hey, we need transportation to get to this to a research appointment," or they say, "Hey, can you come to our community? Hey, can you talk to, give presentations?" We're not going to do it unless you listen to what people say.
Kind of with that, could you speak more about the work that you all are doing with churches and faith communities, and how that's a site to bridge those gaps of mistrust and distrust that go back, like the Tuskegee experiment, as you relate it to Henrietta Lacks and the like. And what is it like to be in a very interesting sort of, crucible space of being, in a southern state like North Carolina, being at a medical school and being a part of a very unique, center named after a quintessential figure and literary and American icon, but who also spoke very poignantly about the problem of race and even Southern peculiarities and the like, how all that helps to shape your work and the work of your team.
So so I can say that, having been part of the Maya Angelou Center, she is an incredibly wonderful figure to be holding up her mantle. Dr. Angelo was a professor here at Wake Forest and lived here in Winston-Salem, North Carolina. And so I don't think that you can live in the area where we live and not be able to understand that people need to be heard, and there are lots of different people here. And if we truly want to do good science, you can't do that only looking at one group. You just can't do it. And we do have something. My director, Dr. Goldie Bird, has created the Triad Pastors Network, which is a group of approximately 100 pastors, mainly of African American based churches. We do have mosques as well, representation. And when you engage a faith leader who has once a faith leader, what we find is that the faith leaders themselves are dealing with Alzheimer's. Either they have it in their families, or they're dealing with congregants who are dealing with it, or have congregants who have Alzheimer's. So these health issues are relevant to the church. And so once you have them on board and invested, they have influence over their church members and can provide opportunities for participation, whether that's in research or other activities. Oh, I can't hear you.
Yeah, thank you so much, Dr. Cabin Hope,
Sure.
for all of your research and your presentation today, and what you shared with us, and your ongoing work and our partnership with you all at the Maya Angelou Center for Research in Healthy Communities. And I know there are a lot of people in the chat who have expressed a lot of interest in your presentation and your research and your work, and whose families have been affected by it. So I'm sure they would like to get in contact with you and stay in contact with you as you continue your work.
Okay, and then what I'll do is I will create probably a more abbreviated version of the presentation for sharing.
That would be wonderful. We very much appreciate it. Thank you so very much for being with us today, for sharing with us and presenting, and for informing our network and our community. We greatly appreciate you.
Thank you. Thank you for the opportunity. Have a great day.
Thank you so much. Take care. Have a great day as well.